to the UK Dementia and Palliative Care Conference 2025 podcast, brought to you by Rowcroft Hospice. Recorded at the beautiful Buckfast Abbey Conference Centre in Devon, this series explores the critical role of dementia and palliative care in supporting those living with dementia. Across these episodes, we'll be sharing expert insights, real-life experiences, and innovative approaches to improving care. Thanks for tuning in. Let's get started. The closing panel discussion, Future Directions in Dementia and Palliative Care, chaired by Dr. Jill Horne, Programme Director of Care Services at Rowcroft Hospice.
Thank you for agreeing to be on our panel. We've had 5 questions submitted from the room, and they're amazing questions. So I will not necessarily ask you to answer them all, but and if you don't want to answer the question, just pass it on to a colleague. The first one, which I think is a lovely question, is who is your palliative or dementia hero and why? Who would like to answer that?
Well, actually, in my team, there's, I think, a hero, Jenny van der Steen. Kevin called her
as well.
Oh, okay. So, and she's a very friendly, quiet researcher, very modest, but she's in every thing that she has committed to palliative care and dementia for, I think, more than 20 years. And she's able to connect researchers all over the world. And so she's a very quiet hero, very modest, but I think she's my hero, yeah.
Oh, well, I would second that, actually. I know Jenny very well. But another person who comes to mind is Balfour Mont. And he was a contemporary of Cicely Saunders, but he was at McGill University, and he actually coined the expression, I think, palliative care. And I was in McGill in February, and they had an honorary lecture, and he sort of was given an award, and he's quite infirm, quite frail, but it was quite an honor to sort of share the same room with him when he received that award.
Yeah. Anybody else? If not, we'll go on to the next question. Have you got some?
Well, I feel an imposter because 3 of my heroes are just to my left here. But actually, when I was a student nurse at Guy's Hospital in 1987, I worked on an oncology ward, and we had a young 23-year-old woman dying of ovarian cancer. I came onto night duty with my senior staff nurse and the healthcare assistant. And the senior staff nurse said, "Sarah, are you up for looking after this patient all night? Because she and her husband need somebody to accompany them, the death vigil, if you like." So all night long, all I did was look after this young married couple as she went through the dying process. She died the next morning just before I went off shift, and I remember going away thinking, if I can be like that senior staff nurse, if I can be the courage to do something different, and if I can support a second-year student nurse in that way, then that is the type of palliative care nurse I want to be. So she's definitely one of my heroes.
Oh, thank you. Did you have anyone?
I was going to mention Jenny van der Steen because I've learnt so much from her, but the other person I was thinking who's been a huge influence to me is someone called Professor Claire Goodman, who is a district nurse, I think, by background, but she really supported me towards the beginning of my career. Has been very encouraging. She still is. She's done incredible work in care homes, and she's been one of the leading researchers in that care home setting, which is very different from some of the other places where I work. And she's done some really important work in pulling together huge sets of data so that we can understand what's going on. And that was really important during COVID as well. So I just wanted to flag her up as well as someone whose work is very impressive. And she's a very good person as well.
Thank you. Thank you for that, guys. So the next question is, what do you think is the one thing that would make the difference to palliative care and dementia in our society?
Mine would be that they're not split off into social care funding, so that all of the funding comes from the same funding stream, whether that's health or social care, or the hospice sector is funded mainly by charity, so that it gets the same funding as other health conditions.
I totally agree. The other thing is that I would want is that, and apologies for my medical colleagues, is that we try and move away from the medical model of care and really move back to that holistic, person-centred care and valuing emotional, psychological, social experiences as much as the physical symptom control. I value the physical symptom control. I value the biomedical model, but we are more than biology and chemistry. We're human, spiritual beings, and I think the experience of palliative care we need to regain that ground.
Maybe it also differs per country. In the Netherlands, when we talk about the end of life, then everybody thinks about euthanasia, because it's possible, and that really disturbs the conversation about dying, because all the conversation, all the news and all the communication by media are about euthanasia. Well, in fact, it's only like 60 patients with dementia die with the euthanasia. But everybody, if you say, well, do advanced care planning, they say, well, they think you are going to talk about euthanasia. And so this really, in our country, hampers the progress of good palliative care and good total spiritual approach of the dying process. So that I would like to see that change in the Netherlands.
Yeah, in actual fact, it's Jenny van der Steen comes to mind again, and it's with respect to the guidelines. And one of the first that she developed through a Delphi process. And one of the statements was recognizing that dementia is a terminal condition. If you recognize that, I think you can move further upstream with respect to the provision of palliative care. And then I used to have an appointment in the Division of Palliative Care and Family Medicine at McMaster University. And my palliative care colleagues, physicians, consults, would say, in actual fact, what we do as palliative care physicians is what medicine should be doing as a rule. So that, the holistic approach, et cetera. So if we recognize that dementia is a terminal condition, that we need to move further upstream, I think it has implications with respect to the type of care that's provided and offered to those living with dementia, including their family as well. So I think, yeah.
Thank you very much. Thank you. So the next question is, what is the role of hospices in dementia and palliative care? That's a very broad question.
In the Netherlands, it's almost people with dementia do not come in hospices. We have very few hospices, so for the Netherlands, it's not a big issue, which I regret.
Do you want to? So the question is, what is the role of hospices in dementia and palliative care?
Well, it would be multifaceted. So, for example, it could be sort of having a dedicated dementia unit, for palliative care. It could be train the trainer with respect to providing that type of training. In fact, when I was talking about the FCDS earlier on, those external facilitators, some of them were with Admiralty nurses, others were actually on secondment from the local hospice. So I think it can be sort of a hub around dementia expertise at the end of life. So there's training, education, and actually the provision of care. So it's not just one activity, but a suite of activities that it can embrace. Yep.
Thank you for that. Yeah. Any other thoughts on that?
I think one of the challenges we have in this country is I think there's over 220 hospices across the UK, and of course they get less than 20% or even less than that funding at the moment. So I think one of the challenges for the role of hospices and palliative and dementia care is how to scale up and generalise what they do. But I also think that we need to work better with it. If we keep on doing the same thing, which we have done for 40, 50 years, we're never going to change how we approach palliative and end-of-life care. So I think there is something about the role of hospices and palliative and end-of-life care to change how we do things, the way we do things, and who we do it with. But we have to do it with others. I think the problem I see at the moment is the silo working. And as soon as money is an issue, it becomes even more siloed. So I think there is something about the role about changing the narrative. And I don't just mean death awareness and things like that. I actually mean the narrative about who has the role and the responsibility, and also how we, maybe with hospices, about how we also bring in the community. So we mentioned, I think somebody right at the beginning mentioned about compassionate communities. We've forgotten all of that post-COVID and during COVID. So sorry, that's a very long answer.
So another question is, I think I'm reading this right, so correct me if I'm not. If there was a new quality indicator for good end-of-life dementia care on the palliative care register, so I'm assuming the person is a GP, what will that quality indicator be in 5 to 10 years' time?
So it won't be avoiding transfers of people to acute hospitals. I think that's really difficult to measure. It's very difficult to measure outcomes and experience. I think a reflective experience, perhaps from the people who are left behind, the carers, the family, and their reflection on the death. We don't have good tools to measure that, but I think if that was acknowledged, that would be a big step forward and perhaps a lot more useful than getting hung up on where people die and what their specific symptoms are.
Yeah, I think the problem with quality indicators is that they do not reflect personal goals. And I think it's very important that we should accomplish personal goals. So maybe we'll be having goal attainment scaling and discuss with advance with the patient but also with the family goals on physical, psychological, spiritual, and then look backwards. Did you attain those goals? So that would be the best, but I don't think that will be in 5 years. It will not be so.
Yeah, I was just reflecting. I'm resistant to rest on an indicator. I think it's in contradiction to when we talk about holistic care. How do we reduce holistic care and its outcomes to an indicator with the risk of myopia? And we do know how the policy shaping community can become fixated on a particular indicator that can be detrimental to the care recipient, their families and providers. So, if there's a compromise, it's actually considering a composite score where you can somehow blend a set of indicators together that reflect a more holistic output. But I don't know how that would transpire. Eludes me. But I'm reluctant in terms of prescribing something. Yeah.
Thank you. Interesting question. Then the next question is there a library of example interventions that others could draw from? And the person's put, for example, clinicians, researchers, carers, a library of interventions, I assume, in terms of dementia and end-of-life care.
What? Say that again, please.
A library of interventions. I know that each of you have given examples like the comfort.
Yeah, no, exactly. I think we heard that earlier on. Maybe it was Zena who was talking about it. There's this gap between knowledge production and knowledge use. And part of the problem is where is that library and how do you make it accessible to the people who need it? And I've been involved and I've witnessed a number of strategies trying to bridge that gap, but so far I think it still eludes us. So it's a bit of, it's aspirational, but I think the issue is not so much where the library is, but how do we close the gap between knowledge production and knowledge use? That's, I think, the issue for me.
Yeah, I agree. Yeah.
I think it would actually be a really good project for someone to just bring it all together in one place.
New project.
Yeah. So I think there are certain places where you can have a look for these things. So the European Association of Palliative Care, I think, has some information on there. But I don't think there's any one repository where someone can go, almost like a recipe where I'm looking after a client or a resident, they've got these issues, I might need to look for something. I don't think we have that anywhere, and it's a really good idea.
For those of you who remember, the National End of Life Care Programme here in the UK used to have a repository of case studies and resources. And when that was abandoned, I think that was a real shame, because it then meant that there was, if we just ignore the IT equity, if somebody can actually access it, but what it did provide is where case studies, contact details, projects, resources could be accessed from one place, and it gave you a starting point. And I'm just reflecting, when we think of, just thinking about across the UK, there are so many hospices, so many services, so many charities have all these different resources, but they're not, unless you know it locally, you don't know it's there. So I think there is something a bit like the old National End of Life Care Programme to try and harness and curate it. But the IT issue is a big issue, and I think we need to really recognise that. What I mean by people accessing it.
So I have a question. Liz, you talked about the Embed project this morning, and the amazing work you were doing to raise public awareness with the exhibitions. We're in this room, we're all here today because we're passionate about care of people living with dementia. How do we influence the people with the money pockets? How do we influence government? How do we influence our local commissioners? What can we do?
I think it's really hard, and it's really hard in the current climate as well, because everyone wants to cut back, and my experience of commissioners is that nothing will happen unless you can show you're saving lots of money, and it goes back to the old chestnut that the only thing they're focused on at the moment is reducing emergency care utilisation and clearing waiting lists. So I think it's about showing them that activity in this area hits one of their targets, which is difficult if you don't actually believe in it. But I think we have to get a bit more probably politically wily in terms of playing people at their own game and saying, hang on a minute, do you realise how many people are coming to A&E that we could look after at home if we had these community services? So I've spent most of the day saying it's not a good marker, but it's almost about talking their language, I think, and understanding what their priorities are, and then tailoring what we do, and also presenting them with solutions, but with good evidence about cost. And one of the things that we really lack in our palliative care research, as well as our practice, is good economic evaluation of the difference that things make. We're currently churning all our economic data at the moment, but it's really complex. And I think, Wilco, do you want to say something about the economic side of things?
Yes, I think that's a very good point, because a lot of interventions are based on is there a good balance between what it delivers and what it costs, and then there's all kind of quality of life measures. So we have the Euroqual, and then you can say, well, this intervention cost €50,000 for a quality life year, and these kind of things work for people age 50 or 20, but when you have people in care homes, they don't work. And we're doing some research and getting better quality of life measures, but also have this. Because we have a very bad experience with this kind of quality of life studies. For instance, we gave cranberries to nursing home patients, and the side effect was they lived for 2 weeks longer, which is very costly. And so this was not a cost-effective intervention, and so. We should determine as a society what we find important, and that should be reflected in a measurement instrument that we can use. But we're not finished yet in that respect.
What was the question again?
Well, it was about, the great work around raising public awareness, but how do we, because we're passionate about dementia care, how do we in this room influence our local commissioners
Right.
and politicians.
Okay, that's what I thought it was. So there's a fellow by the name of Jonathan Lomas who was very big 20 years ago on knowledge translation. And he signaled that you need to recognize the information processing styles of different audiences. So the policy shaping community processes information differently from the administrators versus the practitioners. So you have to know your audience before and then customize the information to influence them. So the information you target the policy shaping community is not the same type of messaging which you're going to provide to providers. So you really do need to know your audience, customize the message, and it could be, for example, policy shaping community may be value for money and economic analysis. From a practitioner community is quality of life and return, in terms of, so for both the family and the patient. So you really have to know what the information processing is for those folks.
Thank you, that's really helpful. So I'd like to open it, we've got a few more minutes. Is there any other questions you'd like to ask these amazing people?
Hi. I'm just very cognizant that we use storytelling.
Yes.
And I'm just linking that with what you just said, and I wondered if that's less impactful for commissioners and politicians.
In fact, I think it's more.
You think it's more impactful?
Politicians want stories. If you politicians want stories, and they respond to individuals. And so if you think of something, say, like Martha's Law that's just come in, that was an individual, terrible, tragic mishandling of care where her family campaigned very effectively. And as hospital doctors, we could have been talking about that for years and presenting reams and reams of data showing that we weren't managing the deteriorating patient properly. But sometimes actually politicians and policymakers respond to stories and personal stories much more than they respond to data. And that's what we're having to learn as researchers as well, I think, how we get that message across.
I would just emphasise that, and I know that within my world, I picking up on the point about trying to tailor it to the audience, and every time I'm thinking, am I telling a story wrapped in data, or am I telling data wrapped in a story? And I have to decide in the moment what way I'm going to do it. But you think about the individual, your relationship, what they see your role is in the moment. So when I'm being a touchy-feely palliative care nurse, I'll tell a story, but then I'll switch in the meeting to say, now let me give you the data, let me give the activities, the outputs, the outcomes, the patient experience, and this is what we can do with this amount of money. But you have to make that decision in the moment.
Right, well, I just want to thank you, all four of you, very much. Give them a big clap. Thank you so much.
That's it for this episode of the UK Dementia and Palliative Care Conference 2025 podcast. A huge thank you to our sponsors, Majestic Holidays, Wallens, Amica Care, MC Hearing and Audley, and to Dementia UK for their invaluable support. This series is recorded and produced by iNarrator and proudly hosted by Rowcroft Hospice. Links to resources mentioned are available in the show notes. If you found this discussion valuable, please share it and stay tuned for more thought-provoking conversations. Until next time, take care.